Well, welcome everyone to yet another wonderful GSA-sponsored webinar. My name is Megan Heising-Sheets, and I am a geriatrician and researcher at the University of Chicago. And I'm excited to provide the introduction to today's presentation. This webinar is really the result of a project that was supported by the GSA Tech and Aging Special Interest Group. And the focus of today's webinar is on the whether and how we can administer functional and frailty measures in this new era of telehealth and remote data collection. Next slide. Thank you. We have a very exciting and diverse panel of experts today to stimulate discussion and bring unique perspectives. And I want to introduce them briefly to you in alphabetical order. The first is Dr. Walter Boot. He is a psychologist and researcher at Florida State University. The second is Brian Buda. He is a health scientist at Johns Hopkins University. We have Dr. Margaret Danilovich. She is the research director at the Center for Jewish Elderly Senior Life in Chicago. She has a background in both physical therapy and community health. Dr. Erin Harrell is a psychologist and researcher at the University of Alabama. Next slide. Dr. Michelle Martinchek is a geriatrician at MGH Institute of Health Professions. Dr. Carrie Neiman is a otolaryngologist at Johns Hopkins University. And Dr. Pamela Toto is an occupational therapist and researcher at the University of Pittsburgh. Next slide. So I've also included here an expanded list of our co-authors on this project that brought additional perspectives from statistics, behavioral health, social psychology, nursing, and surgery as well to this content. Next slide. A brief reminder to use the chat function for all questions. The raise hand feature will be inactive during this webinar, and we are looking forward to having your questions and a discussion at the end of our presentation today. Next slide. I don't think I need to convince anyone on this call that functional and frailty measures are essential to older adult care and research. Our motivation for this project stems from the experiences we all faced transitioning to telehealth and remote data collection during the pandemic. Basically, we were all left to figure out the feasibility of collecting functional and frailty measures over video conference. Next slide. So our project objectives were to help fill this knowledge gap. And our first objective was to conduct a systematic review to explore what has already been published about the safety and accuracy of administering functional and frailty measures over video conference. And our second project objective was to conduct a systematic review to detect or identify studies that have reported the correlation between self-reported alternative questions to those objective measures for instances when either there's not time or it's unsafe to do these over a telehealth encounter. We then used all of this information, pooled it together into tip sheets for administering these measures over video conference calls. Next slide. We focused on 3 commonly used tools for this project just to narrow our scope a bit. We included the timed up and go, the 3 components of the short physical performance battery, and the 2 objective components of the physical frailty phenotype. Next slide. So the agenda for today's presentation is going to mirror our stepwise approach for this project. Part 1 will report our findings on the feasibility, safety, and accuracy of administering these measures over video conference. Part 2 will report our findings about the subjective objective measure correlations. And Part 3 will provide highlights from our tip sheets. We are looking forward to having a very exciting, stimulating discussion at the end, and look forward to you sticking around for the full hour. So stick with us. And without further ado, let me move into part one. Next slide. So for part one, on the feasibility, safety, and accuracy of remotely administering synchronous, objective, functional, and frailty measures over video conference, I would like to introduce Dr. Harrell and Dr. Neiman to present our findings.
Thank you, Megan. If we can go to the next slide. So to start out, we first wanted to be able to identify existing work that had actually looked at evaluating the feasibility, safety, and accuracy of being able to remotely administer synchronous, objective, functional, and frailty assessment over video. In an effort to do that, we took a two-pronged approach. We actually used crowdsourcing as well as literature reviews. For our crowdsourcing, we actually recruited the help of co-authors on this project as well as GSA members. GSA actually has a Connect networking platform that actually has over 5,600 members. So they were actually able to also contribute and help put forth resources that they thought we should be evaluating for this project. In addition, we also conducted literature reviews. We used 3 databases for this. We used PubMed, CINAHL, and Scopus. Another thing that was important is that we had current and recent literature. So we were also looking at literature from the time period of 2010 to 2020. Next slide, please. So for the literature reviews across those 3 databases that I just mentioned, we had several search terms which you can see in our materials. So those are all listed in our supplemental materials that you can review. But in essence, they were categorized amongst basic categories. We were looking for terms that were referencing older adults. You can see some examples of how that may have been expanded there to the right. We were also looking at terms that actually would refer to or include actual functional assessments and performance measures. We also included terms for short physical performance batteries, as well as remote monitoring. Next slide, please. Within those articles, there were also inclusion and exclusion criteria as well. We wanted to make sure that the population sample for these studies actually included adults who were 60 years of age or older, who were community dwelling, that were using English language. And actually, this was a key component, that there was a synchronous administration of measures. And of course, that there was use of video conferencing for that data collection. Articles would be excluded if they were using technology that wasn't readily available to both public and healthcare providers. Next slide, please. Based on our search terms and our inclusion and exclusion criteria, we actually ended up with 461 articles that were reviewed. 6 of those were identified through crowdsourcing, and the remaining 455 came from our literature review. Next slide, please. Once we had aggregated those articles, the next step of the process was to actually do the reviews. Articles were reviewed by at least 1 author, and in that process, only 1 met our inclusion and exclusion criteria. So I'll turn it over to Carrie now to tell us more about those findings.
Great, thanks, Erin. We'll go ahead and do next slide. So what did we find in that 1 article? So I encourage to check it out, Wong et al. In 2017. And it was actually a smaller study nested in a larger study. And what they did was an in-person versus video, virtual video administration of some functional tests, and that's specifically timed up and go and then grip strength. They did it on the same day with the same assessor, and you can see it really only included 17 individuals, so a pretty small sample. Again, it was nested within a larger randomized controlled trial of a tele versus in-person rehabilitation. And I think the other thing, just to keep in mind, just the limitations of the existing literature, is that it was actually done in a separate room in the hospital. So we weren't even talking about a home-based setting here. And they did find that there was high correlation in the administration in the in-person versus virtual for the timed up and go and grip strength. Other implementation challenges, especially given the fact that it was in the separate room in a hospital setting, that internet dropout, visual clarity, and auditory clarity were all some difficulties that arose even in that pretty highly controlled setting. So I think this really emphasizes that the space is wide open for additional studies that do look at specifically the accuracy of some of these functional and frailty measures. Go ahead and next slide. But we also then looked in terms of trying to gather some more information about the safety and feasibility of remote administration of interventions, not so much on the virtual assessment and the accuracy, but what can we learn in terms of some exercise and health assessments that were delivered via video conferencing. And so looking at the protocols, what we saw that a lot of the protocols did require some things that we may not think of for all of our older adults in terms of limiting the generalizability. So the protocols require that individuals had intact vision, that they were able to understand and follow commands, that their other health conditions were well controlled. Again, we're thinking about exercise here for many of these interventions, that they had, functional status was adequate. Obviously, use various definitions depending on the population they were looking at, and that they needed a presence of a care partner to assist. And safety considerations did revolve around things like sensory, cognition, physical limitations, what physical space that an individual had available to them, and what supervision. So again, thinking about the generalizability of some of these protocols and how many individuals have sensory impairments, cognitive impairments, and how to adapt these, there's a lot more research that needs to be done. But that's what we've found in this initial first part. Thank you. You can go ahead, next slide. Perfect.
Great, thank you, Carrie and Aaron. I think we were pretty surprised that out of the 460 some articles we reviewed, we really didn't find much that matched our search criteria. So, really ripe area for research. Let's move on to part 2 now, in which we report the findings about the correlation of the subjective alternatives to these objective functional and frailty measures. And I will invite Brian Buda and Dr. Pamela Toto to report our findings here.
Thanks, Megan. Next slide, please. So I think the work that Brian and I are excited to share now is very complementary to the introduction that Aaron and Carrie gave for us. Our objective was to identify and summarize existing evidence or experiential-based recommendations for implementing subjective alternatives to objective functional performance measures during a remote clinical or research assessment. And our intention was to match so that they would be measuring the same or similar components, the subjective and the objective. Next slide, please. So in this idea of seeking subjective alternatives to objective functional performance measures, we recognize that there's really a need for guidance on collecting functional and frailty measures remotely using safe and standardized approaches. So our first 2 speakers really talked about the challenge of this in general, like, do we know it's safe? But if we are unable to in some way do an objective measure remotely, are there other tools that we can use that can satisfy A, are there tools, and B, can we rely on them as a proxy measure for the objective test? And so our targeted objective measures included balance tests, and that included the side-by-side, the semi-tandem and tandem stances, chair stand, and you may realize that there are different versions of chair stand, but this was in particular rising 5 times from a chair, usual gait speed over a short distance, grip strength, excuse me, the timed up and go, the short physical performance battery, and physical frailty phenotype, which includes usual walk and grip strength. And you may notice there that we're looking at grip strength in 2 different mindsets or contexts. Next slide, please. That pregnant pause. So, so a lot of our work, Brian in just a moment is going to spend a lot of time focusing more on the results and what does this mean for all of us as clinicians and researchers. So our review strategy had this parallel themes with the work that Carrie and Aaron introduced. The idea of our inclusion criteria were people who were 60 or older, that the articles were written in English, again, synchronous administration of the measures, that they reported correlations, and that the articles were from 2010 to 2020, so that was our time frame. If you look at the figure on the screen in front of you, we initially identified 221 articles, and after removing duplicates, excluding because of content, going through our abstract review process, we ended up identifying 31 articles that met the criteria for full review. One of the things I want to point out, because if you're good at math, you're going to notice something when Brian starts talking about the results. We're going to talk about it by objective measure, and the numbers don't match. So we found 31 articles, but we're going to report based on the assessments of 39, and that's because some of those articles did include more than one measure. So don't worry about the math. We're going to give you the the skinny, and give you the dirt on what the outcomes are. So next slide, please. So I'm going to hand it off to Brian, because I think this is really what y'all want to hear are the results and what we can do. Take it away, Brian.
Thank you so much, Pam. Hi, everyone. I'll be talking about the results of our look at subjective correlations with objective measures. So let me start with balance. As a reminder, these are based on looking for balance tests that are the three listed up in the top right corner. And we selected these because they are typically part of the SPPB. So we found 6 studies that met our criteria. 2 of them included all of the objective balance tests that we were interested in, and the other 4 included at least 1. And out of these 6 studies, 5 reported some kind of statistically significant, often small correlation. Next slide. The highest correlation that we found was an R of -0.62, and that was based on self-reported measures of difficulty with stooping, crouching, and we selected that one for the tip sheet. We're going to talk more about the tip sheet in the next part of the presentation. And overall, though, we found that no studies, reported this extremely high correlation between subjective and objective balance measures. And you'll see that no extremely high correlation will be a theme as we go through. Next slide. For 5 repeated chair stands, again, we specifically select this because it's part of the, commonly used SPPB. We found 3 studies, and all of these reported, again, statistically significant but small to moderate correlations. Next slide. Here, the highest correlation we found was for a self-reported scale of lower extremity function that was published by Eleanor Simonsick and colleagues. You'll note that the date is outside of the window that we aimed for initially, which was the 2010 to 2020. I wanted to mention that because when we went through our crowdsourcing, some older articles were recommended and really were relevant to this work, and we didn't want to just disclude them, given that they had some really relevant information. However, for the tip sheet, we because the extremity scale was a bit more complicated, we also wanted to think about feasibility for administering and for making these clinically useful and useful in research. So we ended up also finding pretty good sensitivity and high specificity for a self-report question about difficulty standing up from a chair and in correlation to objective chair stands. So that was selected for our tip sheet. But in the gray box, again, no extremely high correlations were found. Next slide. Usual walk, there were 7 studies that met our criteria looking at subjective and objective measures. 3 studies focused on gait speed 4 meters or less, which was our main target, and some of them reported on gait speeds of longer lengths. In the 3 that were around 4 meters, you can see there were moderate correlations. Next slide. And the highest correlation we found was between objective walking speed and a 4-item walking speed questionnaire that was published by Kong and colleagues in 2016. So we selected that for the tip sheet. Happy to give more details on that if anyone's curious. about what's included in that questionnaire. So again, you see the moderate correlation, but no extremely high correlation here again. Next slide. For grip strength, excuse me, we found 4 studies. 2 of them reported statistically significant correlations, but they were pretty small, as you can see here. And 2 found no correlation or had a really small sample size. Next slide. Again, so highest correlation was still relatively small, as we can see here. It was a 0.36. We also did find in another study some information about diagnostic accuracy between self-reported questions and grip strength. And a couple questions actually had decent sensitivity, specificity, and agreement. And so we thought those would be useful here for the tip sheet. And they were actually questions that were asking about trouble watering plants using a spray bottle, or feeling like you have less hand strength than others your age. So they seemed relevant. And again, we saw some decent agreement measures here. But as you can see, correlation-wise, there was no high correlation. Next slide. Timed up and go test, which we talked about previously in part 1. So we actually found a lot of studies that were looking at this measure in relation to some kind of a subjective questionnaire or question. And 11 of those reported statistically significant, again, small to moderately high correlations. Next slide. So the highest correlations were with some different scales that some of you may be familiar with, like the KOOS scale, specifically the ADL KOOS, as well as WOMAC function scale. So you can see that there are some decent correlations between these scales. However, when you look at the studies, they often had pretty small sample sizes, or they were pretty focused on specific patient populations. And given those factors, and also given some of the limitations of feasibility with these longer scales, we don't make a sort of a recommendation here for a subjective assessment. But and once again, there really were not high correlations, though these are pretty good. Next slide. And short physical SPPB, so 2 studies, and both reported moderate correlations. Next slide. Highest we found was a R of 0.65 among older adults. This was using a WHO disability assessment, which gets at a number of different domains, as you can see here, and that was correlated with SPPB. Again, there's no high correlation found, and given that SPP is made up of 3 of our previously discussed targeted measures, balance, chair stands, and usual walk, we think the findings from those could be useful for how to sort of get the information you need for a remote SPP assessment using subjective questions. Next slide. Finally, physical frailty. So we identified 4 studies. As you'll see, these were studies looking at objective and subjective physical frailty measurements, basically substituting for the objective criteria in the physical frailty phenotype, slowness and weakness. But the correlation studies really aren't there from what we could find. We did find some studies looking at sensitivity, specificity, and kappa agreement. So on the next slide, I'll talk a little bit more about those. Next slide, please. So you can see in one questionnaire, there was a 94% specificity for identifying frailty using the self-report measure. And in other studies, especially one with Kirsten Johansson among hemodialysis patients, they also found pretty strong sensitivity in NPV for their self-report measure. Again, there were no correlations. So when we thought about how to make a recommendation, we thought it was probably best to look at the gait speed and grip strength recommendations that we previously mentioned in terms of informing some kind of subjective frailty measure. Next slide. Okay, so in summary, here we show by objective measure, what we included in the tip sheets, related to subjective alternatives. So again, there's 1 question for balance, 1 question identified for chair stands, a 4-question scale that has a sum score for gait speed. Grip strength, we found 2 questions we thought were useful. The timed up and go tests we didn't feel comfortable making a recommendation given the limited data and the smaller sample sizes and that we found. And then again, for SPPB and for frailty, we think that looking at the above individual measures and how they can fit into those aggregate scales could be useful for subjective assessments. Next slide, please. So to again summarize, we found moderate correlations between our targeted objective performance tests and self-reported measures for pretty much all of the individual measures except for grip strength, where we found small correlations. No studies reported extremely high correlations, as I said many times, and this is suggesting that these tests are, they're indicating related but distinct domains of function. We are limited by things like small sample sizes and clinical settings, and that can affect, generalizability of recommendations here. We think the self-report measures can serve as perhaps screeners for persons at potential risk for functional deficits. And we think that in some, in cases where the correlations are decent, that self-report measures can also be used to safely, when safety is a concern, before we do some kind of virtual objective testing. Overall, I just really want to encourage that more research is needed on these subjective and objective comparisons. And one thing we'd like to, try to pursue or to suggest to others to look into more is identifying these sort of ideal sensitivity cut points, for screening and/or safety purposes, using subjective alternatives to objective tests. And next slide, I think that's it for me though. So thank you.
Great, thank you so much, Brian and Pamela. I know that was a lot of data to summarize in a few slides. And to the degree that our literature search was done, and basically there's a lot of limitations in what we found. And we are drawing some conclusions and taking that information that we found and putting it into tip sheets, but it's based on very limited research. So I want to move into this third part now, part 3, the remote administration of objective functional and frailty tools, by inviting Dr. Michelle Martinchek and Dr. Margaret Danilovich to give us some highlights of what these very first tip sheets are going to look like. But remember, this is the start of a conversation, a start of an effort. There's a lot of work that needs to be done in this space. So take it away, Margaret and Michelle, and let's look forward to a great discussion following this section.
Thanks, Megan. Great. So really excited to jump in now on how we actually use these tools. So next slide, please. So before we even jump into any of the tools, one of the things we really want to highlight across the tip sheets are some of the general considerations for administration and recommendations. So you can refer to the tip sheet for the details and the specifics, but the key takeaway points that we want to emphasize are that virtually you probably need to take more time to set up your environment, to ensure safety, all of those kinds of things that you might not have in the face-to-face environment as much. So really the validity of your measurement is sort of dependent upon having the right environment, being able to view the measure. And so we want to encourage everyone to, think about things like making sure your video camera or the person's video camera really faces the direction of the test, that you can view everything in the frame. You almost need to sort of do a maybe trial to just make sure that you can kind of see everything. You'll need to ask the person, if there is space in the home, either space in the room, but also just sort of space with furniture and obstacles and all of that, and to make sure that people have the right equipment. So things like a chair that's not a desk chair on wheels, that they have a stable surface so that you can safely conduct these measures in this virtual remote environment. We want to emphasize that people can sort of utilize both the subjective and/or objective measures, sort of depending on the circumstances, depending on what you see, and also to really be cognizant of the role that both visual and hearing impairments may have on the impact of administering the test, but also the scoring and how you interpret that score, and sort of incorporating that with bandwidth challenges and the delay that people might have over the internet that impact this virtual assessment. Next slide, please. So the first measure that I'd like to talk about is the virtual walking speed. As mentioned in the previous section, there's a self-report gait screen, these 4 walking speed questions that you can use as your subjective assessment to either drive your objective or perhaps in place of your objective virtual walking speed assessment, depending on the circumstances. These 4 self-reported questions are shown here and will be found on the tip sheet. The threshold here that we're sort of looking for is a score of 13. So scores less than 13 would probably indicate that there's a need for more objective measurement of someone's walking speed and mobility. Next slide, please. So when you're embarking on doing an objective virtual walking speed, referring again to those sort of environmental questions to make sure that this is safe and feasible within someone's environment. You're going to need materials to measure out the path of walking, and ideally having sort of this buddy, caregiver, partner, other person that can assist with some of the administration items. Because one of the things you're going to need to do is measure the actual walking path. Since your walking speed is in feet or meters per second, you'll need that distance. So you're either going to look at the 3 meter or 4 meter or 15-foot walk distance, since those are the distances that have been validated. The person or patient's going to start at one end. They're going to walk their distance at their usual speed with their usual assistive device. And so this is where your ability to see the entire testing area is so important, because you need to start your stopwatch when they start, and you need to stop your stopwatch when they reach the end of the walking course. So setting up that camera, setting up the environment is really going to be key to accurately assessing walking speed. Next slide, please. The 5 repeated chair stands, again, mentioned as part of SPPB as a standalone test here. We can look at self-reported difficulty with chair rise as our subjective measure. Any report of difficulty would indicate sort of a positive screen that would need further objective measurement. Once you have safely set up the environment, you may wish to trial a single chair rise stand to determine safety, especially because the administration directions for this test indicate that the person should stand without using their arms to stand. So trialing that one as a sort of screener to make sure that the person can do it and can do it safely is really key. If the person has another individual they're available for testing, that person can be there sort of on the side to ensure safety, to make sure that the chair doesn't tip back. Your instructions here are going to be to stand up straight, meaning that their knees extend fully as quickly as you can 5 times in a row. You are starting when you say go, stopping at the 5th ascent, and recording the number of repetitions. You can terminate testing at 1 minute if the person has not finished these 5 chair stands, or if at any time it appears that the testing is becoming unsafe. Next slide, please.
Great, thank you, Margaret. And I'm going to be presenting the rest of the tip sheets. Next is the tip sheet for virtual standing balance. This includes a self-report measure, which we mentioned earlier is a single question. The question is, how much difficulty, if any, do you have stooping, crouching, or kneeling? And a positive score is any level of difficulty. This tip sheet also includes a safety screen like the other measures, and you can see that in green on this slide. And participants are encouraged to use a buddy and their glasses or hearing aids whenever possible, similar to the other measures. I'll talk about materials and administration on the next page. Next slide, please. So safety considerations are very important for this balance measure. So in addition to a buddy, patients are instructed to have a chair nearby for support. And again, this is a sturdy chair without wheels. They are asked to stand 3 different ways. So the first is a side-by-side stance where they stand with their feet together. Then they are asked to stand in a semi-tandem stance with the side of the heel of one foot touching the big toe of the other foot. Finally, the last one is a tandem stance where they are asked to stand with the heel of one foot in front of and touching the toes of the other for 10 seconds. The goal is really to have them hold each of these stances for 10 seconds, and they're told to stop after that point. But if they step out of position before them or grab onto the buddy or chair, the examination is ended. If they're unable to complete one of these stances, the test is over. Next slide, please. Next is the tip sheet for the virtual timed up and go. As was mentioned earlier, the COOS ADL and a few other tools did demonstrate just modest correlation with the timed up and go in very small and specific samples. So we felt that we really need more literature to select a good self-reported alternative to the timed up and go. And so our group has decided for now to list that there's insufficient evidence for a self-report measure for the virtual timed up and go. Similar to other measures, we do include a safety screen here. And materials that are necessary for the virtual timed up and go test include a tape measure and masking tape, a walking space, again, a sturdy chair, and a stopwatch. Next slide, please. For the virtual timed up and go, participants are instructed to walk 3 meters away, turn around, walk back, and sit down. They may use their mobility device as needed, and we suggest that for safety, the buddy walk alongside the patient as needed. This measure is then scored using published tools with specific thresholds for increased fall risk. Next slide, please. Finally, the last tip sheet that we've created is for grip strength. We included the 2 self-report questions mentioned earlier, including, do you have trouble watering plants with a spray bottle, and do you feel like you have less hand strength than other people your age? And a positive screen is yes to either question. There is also a safety screen for this measure, again showed in green on this slide. The real challenge with the virtual grip strength is in the equipment. So measuring the grip strength requires a handheld dynamometer, which may be challenging to get in someone's home if they're in their home while you're doing this assessment. If the equipment is available to them, ensuring it is positioned correctly is also important, and so that's where the setup before the test comes into play. The arm should be held with a 90-degree elbow position with the forearm parallel to the ground. And a total of 3 repetitions are done with the dominant hand and scored via standardized scales. So with that, we've now reviewed all of the tip sheets, and we can go on to the next slide.
Thank you, Michelle and Margaret. Dr. Boot, take us to the end.
Okay, so now we'll talk about some conclusions and recommendations. So can I have the next slide, please? So I think everyone's heard an overall theme with what's been presented so far is that we need a lot more evidence, that this is really a great field for people to be working in. There's little evidence that exists for the remote administration of frailty and functional measures during synchronous video interactions involving novel technology. So there's been a push by NIH, for example, for standardized measures. The NIH toolbox is great for standardized measures of cognition and mood and these types of things. We believe that similar efforts should be taking place to target remote administration protocols. So there's a set of remote measures that we can all use that will be standardized with kind of great safety protocols and standard administration rules. Our efforts that we've presented today has been based on the literature we've been able to find, but also this is largely based on expert opinion due to the lack of publications that we've seen in many of these publications having relatively small samples. Next slide. There are issues with respect to technology that we discussed in the tip card, security and integration into healthcare systems, and these are all things that should be considered when we're thinking about remote administration of frailty and functional measures. Most studies utilized that we looked at additional novel technologies, for example, wearable sensors or accelerometers or Wii controls, kind of a video game controller, balance pad or scales. This may present a challenge because many patients and many healthcare systems may not have these additional tools with them, so you'd be able to use these and integrate these into virtual assessments. And in terms of what we reviewed, few technologies reviewed were capable of securely transmitting data as well with respect to HIPAA and high-tech compliant mechanisms. And currently none are really routinely integrated into electronic medical record platforms. So there are some technologies out there, but there are limitations in terms of security, integration, and availability of that technology. Next slide. This is kind of a theme that Brian mentioned and others have mentioned, that when we looked at correlations between objective and subjective measures, self-report measures, there are often modest correlations. Several studies focused on patient populations, and again, sometimes very small populations, very small samples, which can limit the generalizability of the correlations in these studies. But self-report measures can serve as screening tools for persons at potential risk for functional deficits, and then could be verified later with objective tests, either virtually, like we've discussed today, or in person when that's possible, when that's feasible. Next slide. So we discussed a stepwise approach to administering these measures. There are safety issues to consider, for example. So in our tip cards, there are safety screening questions that can help identify individuals who may be at risk or too great of a risk for objective measures conducted virtually. So these are individuals who may be at risk for injury. For this group, we provide a list of subjective, functional, and frailty questions that have reasonable correlations, modest correlations, that may serve as surrogate assessments until in-person safe measures can be conducted. For people without safety risks, we include in our tip card a list of supplies necessary to carry out testing and instructions, sample instructions for objective measures that can be conducted virtually. In really all these cases, the presence of caregivers or helpers may be important to protect the participant's safety, and that's highly advised. Next slide. So telehealth, I think one conclusion is that telehealth is here to stay post-COVID-19. Hopefully one day we will be post-COVID-19, but even post-COVID-19, these are all really useful assessments for a number of reasons. To be able to expand the reach of clinicians and researchers to collect data on frailty and function remotely. So these are tools that allow for broader reach of geriatric assessment to those who don't have access to geriatric care. There's also a significant benefit to research as well. And also we know a significant need to test the best ways for these measures to be administered, both with respect to good geriatric clinical practice and to test for their appropriateness for important research outcomes. So in terms of final conclusions, future research should focus on further guiding best practices in this area, both with respect to clinical work, but also research. The NIA has promoted the inclusion of older adults in research studies. Anyone who's submitted an NIH grant recently knows that you have to do this, unless otherwise there's a good reason not to do this. And remote data collection strategies could help facilitate the enrollment and retention of these participants. More research is needed to identify valid self-report alternatives to objective measures, or in addition to objective measures, when safety precludes objective testing. This is an important area of future research. And also standard approaches, such as those outlined in the tip sheet, would help to standardize administration protocols and allow for better comparisons of data across clinical samples, but also for research purposes as well. Next slide. Okay. Is it back to you, Megan?
Thank you. Yes, thank you to all of our panelists and all of our attendees today. This was a really large lit review undertaking, and I think all of us have come out just much more knowledgeable about the gaps in research and future directions for this space. In the time we have remaining, I want to take questions from the audience, so please feel free to put them in the chat. I want to maybe get us started by getting a little real with everybody on the panel. We all lived through this. We all faced trying to do functional and frailty measures remotely, transitioning to this remote data collection and telehealth visits. Tell me what you guys did. Did anyone have any experience trying this? how did you get through it? Was it safe? Did it work? Did it not work? Did you just decide to drop it? Tell me what the status is and how you guys handled it.
Megan, I can go first. I'm part of a large study right now that's funded by the National Institute on Aging. It's called Macro, and it's a offering choice, a client-centered sort of home-based or hybrid cardiac rehab program for frail older adults to try to reach that population who typically might be asked to go to cardiac rehab but do not go. And it's a study that's currently happening right now between Washington University in St. Louis and the University of Pittsburgh. And the SPPB was our primary endpoint and our primary outcome measure, right? Like when COVID happened. And we were really invested in continuing the study. And the fact that some people who were randomized into the intervention could complete their cardiac rehab at home, like sort of incentivized. So the intervention was perfect for the world, but how do you assess those measures? And we spent a lot of time thinking about, could we do these remotely? And part of the problem is we didn't know if their environments were safe to even exercise, let alone do the SPPB. In our particular case, we had a number of outcome measures, and so we pivoted, and we one of the measures that we had was more focused on disability. It's called the Activity Measure for Post-Acute Care, or the AMPAC, and that was already one of our outcomes, and so we pivoted, and it is not duplicative of the SPPB, but I was reminiscent when Brian was talking about like the World Health Organization disability assessment. So we went another direction, and we're currently still using the AMPAC as our primary endpoint, and we're bringing back the SPPB in as we can see people in person again. But it was really a lot of even people of our group, it was a mind shift, right? Because if you're really used to using this performance-based measure and it's pretty robust, what does that mean? In addition to reformulating what your sample size needs to be and your cut points and your scores. So, it just so happens that my area of expertise is I was the AMPAC CAT contributor. So as a researcher, I was kind of, put in this extra tool, and then suddenly I became the expert for the primary outcome, and that's pretty daunting. So not only are we doing remote, but it's a big mind shift and a lot of more responsibility. Will this self-report tool work? So
that's great. And is it measuring the same thing? I think from our research we realize it's capturing something
right.
sort of related, but maybe not the same thing. So that's really interesting. I think you are probably not alone in having some of these large studies have to shift to different measures. Anyone else have any experiences you'd like to share?
Megan, I'll jump in. I'll just say, I think we have done some fall screening assessment virtually. And so, I think the lesson learned for us is the need to plan for more time. So doing something like a 5-time sit to stand, in the clinic, it's like, I can do that in 45 seconds because the chair is there. We just get down, instructions, go. But virtually, it's like, oh no, that chair won't work. Go find something else, 5 minutes later. And so it is really, I think from a logistics standpoint, the telehealth is great because we can access people, but in some ways, I don't know how much time saving there is because the visits themselves in some ways do actually take a little longer to complete.
I think that's a really interesting point from a clinician perspective in general. Our telehealth visits weren't any longer. We just got the same time slot. So to the degree that Medicare is reimbursing for some of these, like we haven't adapted to that yet. So I think it's a really, really good point, especially as people are becoming more and more frail and requiring longer assessments and how much time that'll take. I know, Michelle, you had a study that was also sort of shut down and you guys had some adaptations as well. Do you want to talk a little bit about that?
Sure. So we had started a pilot trial of a high intensity walking program in surgical patients just prior to the pandemic, and as with all of you, got shut down kind of when everything started in early 2020. We went through a lot of iterations of how do we move forward and what is the best thing for our patients, and ultimately decided to transition to a telehealth model both for the therapy. It's a little bit of a unique situation in that the patients are still coming into clinic for surgical assessment, and so that gives us the opportunity to do all of our physical function measures at those clinic visits. So it is a bit of a hybrid model, and that's something that I've been using in my clinical practice as well, as if the patient is in the clinic doing some of the physical function measures there, and then kind of following up virtually. So just kind of our own experience throughout the pandemic.
I think thank you, Michelle. The other really interesting, I think, unique angle to that study is that in order to sort of safely deliver that high intensity therapy virtually, like Pam's study and now your study, they actually are buying O2 monitors for all the participants, like sending them equipment to help make it feasible and help make it a little safer to monitor. So I think that's, you know, something to consider, the cost of the equipment that might be necessary for either research or clinical care practices to make that a feasible delivery mode. I'll just throw in a couple of comments. One is that, you know, I work in primarily a frailty assessment clinic. This is our entire visit. So we basically just didn't do anything for a while because I didn't know how to do it. And so, you know, we started, you know, I tried to do, I think chair stands, especially in balance, are a little easier to keep someone in the window. So those were the ones I tried to do first. But I have to give a huge amount of credit to our therapy colleagues, especially in the clinical setting. They took off on the virtual therapy, and I often relied a lot on their assessments. I feel like they were more comfortable with just administering these over virtual visits and started delivering virtual rehab. And so sometimes I would send a patient over there and actually gather data from them. So I feel like they've really mastered that clinical delivery of both the assessments and actually even therapy. And so some people have successfully done it, and we have a lot to learn from their clinical experiences. I want to maybe take this kind of experiential reflections and talk now about the future. We restricted our lit review to technology, for example, that was broadly available to clinicians and patients. We intentionally did that because right now that's all we have. But we do have innovation space. We do have ways to imagine or reimagine what life could be like in the clinical and research space and a remote data collection. What's your wish list? Where do you guys think we should be going? How can we advise people on developers, industry, researchers who are trying to facilitate this, clinical administrators who are thinking about this pathway long term? What do you guys want to see happening?
Megan, I can just jump in. I know for us, we can't overlook the fact that technology is such an important piece of this, but also can be a major barrier. And just recognizing that you figure out ways to do this, considering that, you know, it's potentially a majority of older adults don't have these technologies that are in their home and ready to go, even internet access and things like that. So that's been something that we've been, you know, we meet with our community members, patients, participants, and get that kind of feedback. So that's just a larger sort of infrastructure challenge that I think we are encountering. And you know, how do you deal with that? I think something that we are struggling with a bit. The other thing I would just mention, somewhat to your last point, but also to this question, is that these continue to be extremely relevant questions. You know, even though we're not on research lockdown like we were last year, we're still struggling to find the best ways to sort of recruit older adults into studies. You know, we can't go give healthy aging talks in retirement communities like we could before. And so, you know, how can we do more things remotely? And how can we figure out someone's frailty, you know, over the phone or in a remote visit in enough of a way to sort of have them in we have a registry of people interested in research, and it's important to sort of know some of their functional baseline, even to get them into our studies. So yeah, so I think more work in all these areas is just really, really important going forward.
I appreciate that, Brian, that this isn't like an issue that just went away now that, we're starting to resume some data collection. I wonder, on your point about sort of access to technology, the digital divide, disparities in internet access, Walter, if you do a lot of this work, actually, tech and aging, do you want to just give us kind of some of your thoughts on just globally, how do we approach this? What has to happen in parallel if we're going to continue using tech as a strategy to help facilitate data collection?
Yeah, I think those are great questions. I mean, the latest Pew data shows that only 75% of older adults, it keeps getting better. 75% of older adults are online. 25% of older adults don't go online. One of the most striking things is that when you compare 2019 and 2021, you would think the pandemic would have shifted a lot of older adults to be online because of the benefits there, but it went up from 72% using the internet to 75% using the internet during the course of the pandemic. It was better for smartphones. So about 40% of older adults don't own smartphones right now. The majority of older adults do own a smartphone, but if we're talking about smartphone assessments of all these types of things that we could use sensors in smartphones, we have to recognize that there's still going to be a big digital divide there. In terms of what we do about that, I think one thing that we need to recognize in all of this is that if we're using technology for these methods, there needs to be training. So one thing that's been extremely useful to us here at Florida State University is that our Institute for Successful Longevity put out a Zoom tutorial for older adults who have never been on Zoom before. And it's just been an invaluable resource to researchers, but also community members as well. There's obviously the benefit that older adults can now kind of socialize in a way that they couldn't before through Zoom. But for us as researchers, if we want to conduct remote assessments, and we've been doing this, we can send them these guidelines for how do you get onto Zoom. And that's been really, really useful. So I think we shouldn't underestimate the importance of training and training materials to get people to the point that we could then use these remote virtual methods.
I think that's great, and considering these mechanisms, we really have to think about the whole picture from the start of sort of, are they even able to connect to the technology? Do they have the resources? Can they access the resources? Can they use the resources? Do they know how to do it? Is it adapted to their skill level? All have to come at the same time as these mechanisms for innovating in the data collection space. I want to specifically call on Carrie now, not to put you on the spot, but you think about sensory function a lot, and I'm just curious, how are we going to do these telehealth visits if someone can't feel, they can't see, they can't hear? Tell us what kind of adaptive equipment might we think about, or how we overcome this?
Yeah, great question. Thanks, Megan. I think as we all saw time and time again, in terms of thinking about the sensory side of things, at least on the hearing side, we know if we look at everybody 70 years and older, 2/3 have a clinically significant hearing loss. If we look at everybody in the US, 80 years or older, over 80% have a clinically significant hearing loss. So I think that's step one, is that if you are interacting with an older adult in any setting, you need to assume that they have some degree of hearing loss. In some ways in a virtual setting, I think it is a little bit easier to compensate in terms of trying to make sure that they adjust the volume, trying when possible that you have a headset to try to help boost that signal to noise ratio, that your face is lit, that they can try to, make out your facial expressions, read your lips, things like that. I think it's some of the basic things we can use in clinical practice in terms of teach back methodology, when possible, try to provide written instructions to, echo what you're instructing. So I think those are some good practices to incorporate throughout. It's a little bit harder when it comes, if they're not sitting and they are needing to do something, whether or not they themselves also, you encourage them to have some type of headset if possible. But obviously that's a little bit more challenging. And I think the other thing, just to kind of put a plug in, we know in particular for self-reported hearing difficulties are not necessarily very accurate when it comes to actually, audiometric evidence of hearing loss. And there are a wide range of ways that we can try to capture audiometric data, from apps to online hearing screening to tablets and different things like that. So if anybody's even remotely thinking about the hearing side of things, I definitely recommend exploring options, because there are some objective ways we can try and get at that. So thanks, Megan.
Thank you. No, thank you. I really appreciate everyone's comments and thoughts. I think, fixing these kinds of issues is really going to take a multidisciplinary team like this. So I appreciate everyone's perspective and experiences. I know we're right at the hour, so I'm going to move on to the next slide and just remind people, I believe the next slide is on, that a survey will be sent out. Yes, a webinar evaluation is going to be sent out to attendees. Please, please, please respond with comments there. We are trying to keep this effort going. So we'd love to include more people if you're interested, and love some feedback on the webinar. Thanks again, next slide, to GSA for sponsoring this project and helping to design our tip sheets. We will make them available to you. They're actually in the graphic designer's hands right now. So we will send those out, as well as our full report, to people and make those available online as well. Thank you all to the panelists, to this great group. Hope to see movement in this space moving forward, and maybe we can update our guidelines in the next couple of years when people started to do some more literature research. All right, thank you everyone. Have a great day.